Thank you for the opportunity to speak with you. My name is Tariro Makadzange. I'm a physician scientist and CEO and founder of Charles River Medical Group. Today, I'm going to speak to the challenge and promise of HIV therapeutic vaccines. So I am going to give a very brief introduction into HIV vaccine success and failures to date, and the rationale for thinking that CD8 T cells may be an important component of viral control and the key components of an effective T cell vaccine. I will speak about vaccine, immunogen design, immune modulation, and end with a brief discussion of broadly neutralizing antibodies. So the history of HIV vaccine development has been quite long, with the first vaccines being developed in the 80s. These vaccines were really targeted at trying to generate antibody responses, and most of the vaccines to date have really focused on generating antibody responses. Similar to the COVID vaccines that have been highly successful in the last year, the focus initially was on developing vaccines that focused on the HIV envelope, with the early vaccines being targeted at clade B HIV envelope. These studies continued and unfortunately have had limited success to date. Most notable in many people's minds is the AIDS Vax initiatives, focusing on either clade B alone or a combination of clade B and E. In subsequent years, the thinking was combining these protein subunit vaccines with viral vector vaccines may help improve the immunity. So we saw the combination of the AIDS vaccines together with Alvac, a pox viral vector, in a heterologous prime boost strategy. In the mid-2000s, there was a lot of scientific thought that CD8 T cell-based vaccines may be very important, given that envelope-based strategies had had limited success. So we saw in the mid-2000s the development of CD8-focused vaccines, in particular the Merck vaccine that was an adenovirus-based vaccine expressing GAG, POL, and NEF, and clinical trials done in North America as well as in sub-Saharan Africa were done, and unfortunately those were not successful. In addition, people started to look at combinations of viral vectors plus DNA to evaluate efficacy, and those studies moving into the late 2000s into the 2010s were done and unfortunately had limited success. To date, we have more recent studies, again, using viral vector-based platforms, and I will talk a bit more about the data from that. The only successful vaccine to date has been the RV144 vaccine. And this vaccine, as mentioned earlier, was a combination of a poxvirus vector as well as a protein subunit vector. And it was a large study conducted in Thailand, and in a modified intent to treat analysis had efficacy of around 31%. However, when they looked at the correlates of efficacy, it seemed as though having antibodies directed to the V1, V2 loop was inversely correlated with the rate of infection, whereas IgA antibodies were positively correlated with the rate of infection. As mentioned, most of the vaccine studies have really focused and targeted on prevention and responses towards envelope. In a therapeutic setting, to date as well, unfortunately, the success has been relatively limited. So we conducted a evaluation of vaccine trials, therapeutic vaccine trials that have taken place over the years, and looked at the viral vector platforms, the type of responses that they generated, and the set points that was changes in set point that were achieved. And you can see across the board, there have been various different approaches using different viral vectors. using peptide vaccines. In the 80s, 90s, there was a lot of interest in peptide vaccines, not only in HIV, but also in oncology. Nucleic acid vaccines, DNA and mRNA vaccines, dendritic cell-based vaccines, as well as inactivated virus vaccines. And the different vaccines had different levels of inducing T cell responses, but almost all of them uniformly had limited impact on set point or the viral reservoir. And this was work nicely put together by my research group when I was previously at Gilead Sciences. But what sticks out from this data is that viral vectors tended to induce the strongest CD8 T cell responses and more consistent compared to other platforms, but unfortunately to date have not shown efficacy. So why do we think that CD8 T cells are important? CD8 T cells are a key component of the immune system and help to control viral infections. And in several studies, this is an example of one from many years ago now, depletion of CD8 T cells in animals that had control of the viral load led to a very rapid increase in viral load. This depletion is transient, and so as CD8 T cells came back, that restoration of CD8 T cells reestablished viral control. So again, suggesting that CD8 T cells are likely to play an important role. In other non-human primate studies, particularly in vaccine studies followed by challenge, broad HIV-specific T cells have been associated with reduced viral load. And that can be across different viral proteins, most notably GAG, but also T cell responses to pol and envelope have been associated with decreases in viral load in non-human primates. What is the data in humans? Well, in humans, there are a subset of individuals who are known to be slow progressors or long-term non-progressors, as well as those who are classically defined as elite controllers. And these are individuals who maintain low viral loads in the absence of therapy, some to undetectable levels to copies below 50 copies per ml. And in these HIV long-term non-progressors and controllers, it has been noted that the CD8 T cells tend to have a very good proliferative function. They're cytolytic, so they make cytotoxic granules such as perforin and granzyme, and they're less exhausted than the CD8 T cells from other HIV-infected individuals. This was also showed by other groups showing that long-term non-progressors had T cells of increased polyfunctionality, proliferative, and killing activity compared to those who were progressors. So this is a measure of proliferative capacity. In addition, HLA alleles have been associated with HIV control, and HLA alleles are really important for the presentation of foreign antigens, such as viral antigens, to the CD8 T cells. And this is one study, but there have been several genome-wide association studies that have shown that certain HLA alleles, such as B57, B27, B08, are associated with viral control. So again, suggesting that T cells may play an important role in control. However, the biggest challenge in HIV is the degree of diversity. And in natural infection, we find that people generate T cell responses that are targeted to some of the most variable regions, so areas with high entropy scores. And this is looking at the Los Alamos database and the number of epitopes that have been defined in certain viral regions and viral proteins. And you do see that highly variable regions in most patients do induce good responses. However, there are limitations to this data. It's dependent on the populations and the HLA diversity. The clinical status is heterogeneous in most of these studies, with some folks being latent disease and others early. And also consensus peptide sequences are being used to evaluate these responses. But in general, we do see good responses in areas of high entropy. And this is one of the biggest challenges for designing therapeutic vaccines for HIV. And many of you have seen this before, but it's a very striking image. So if you look at the amount of diversity in a single year of influenza, it's comparable to the amount of diversity in a single individual after several years of infection. There's even greater still diversity in a cohort of individuals in the same geographic area. And in some geographic areas where you have multiple clades circulating, you have even more diversity. So the amount of interpatient and intra-patient diversity is very, very high. And this does translate not only in pre-ART levels in circulating virus, but also in reservoir diversity. And we may be limited in capturing the amount of diversity within the reservoir. In addition, there's host diversity. Different populations have different HLA alleles, and we know that those HLA alleles drive host immune pressure and response to infection. So therapeutic vaccines really need to be able to induce very broad polyfunctional T-cell responses, ideally in conserved regions, and those responses should be able to be functional enough to generate good immune-mediated control. So we think that the components of any therapeutic vaccine, whether it's HIV or cancer vaccines, really needs to touch on these three specific areas. So having a very good vaccine platform, so platforms that we think in the context of HIV will likely induce strong T-cell responses, and there are a variety of different platforms to consider. Very thoughtful immunogen design. So again, taking from cancer where there has been a lot of work done in identifying the right epitopes that not only are good at being processed and presented, but can also induce functional T-cell responses. And some of those may need combinations with immune modulators to enhance their functionality. So I'm going to touch on vaccine immunogen design and some historic perspectives on that. So various approaches have been taken in the past to design vaccine immunogens, and whether it's been full-length approaches, either focused on single clade and typically using either consensus sequences or center of tree analysis, mosaic antigens would try to achieve a full-length sequence, but covering the broad diversity that exists within HIV. More recent approaches have focused on conserved regions as well as regions where there are associated protective epitopes. So the full-length of vaccines, a good example of that is the Merck vaccine. So the Merck adenovirus 5 vaccine was a clade B trivalent vaccine with full-length sequences of GAG, Hall, and NEF. That vaccine was given in 3 doses, and a fairly large study looking at efficacy, so 3,000 individuals' efficacy at reducing infection. And what they found is that the vaccine was very effective at inducing CD8 T-cell responses, and we know that adenovirus vectors lead to very good protein expression and do induce strong T-cell responses. However, it did not lower the frequency of HIV acquisition or post-infection viremia, and there was some suggestion that those immunized, and particularly those immunized and those uncircumcised, were at increased risk of becoming infected. So these full-length vaccines did induce good responses, but in this case, the vector backbone might have had an impact on the efficacy of the vaccine. And in particular, people who had pre-existing immunity to the vaccines, so those with high antibody titers, tended to target fewer regions of the full-length sequence than those who had lower titers. And similarly, in the data, those who had higher pre-existing immunity seemed to be more at risk of acquisition. when looking at the T cell responses more carefully, one of the things that was striking is that the median response across the board was not very high. And here in a subset analysis, the median response was 1. And the median response specifically to HIV gag was limited and down to 0. However, those who had good breath, so targeted 3 or more gag epitopes, when they became infected, had slightly lower viral loads. And again, as expected, those who had protective HLA alleles had significantly lower viral loads than those who didn't. So from the studies with the full-length sequences, we learned that the full-lengths are immunogenic, but you may not get the amount of breadth that you need, and choosing the right viral vector and preventing that pre-existing immunity may be important. So subsequently, researchers have developed these mosaic approaches to vaccine development. And one of the key scientists who has led this is Betty Korber. And the idea with a mosaic vaccine is to try and design a vaccine that will be able to cover all people. And it's a reasonable goal because it shouldn't matter if you're acquiring HIV in Africa or Europe, it would be ideal to have a vaccine that can cover everybody. And the idea here is to take advantage of recombination events that happen with HIV to generate in silico a recombinant viral sequence that tries to cover as much of the circulating clades as possible. And so with that approach, they designed these full-length immunogens with a mosaic sequences and put them in a new viral vector, the AD26 viral vector, through work done together with J&J. And in addition, also used a protein construct, so similar to the early vaccines, to try and further boost that humoral immunity. In early preclinical studies, those mosaic sequences were highly immunogenic and improved the breadth of response from the 1 that we saw with the AD5 up to 9 in the preclinical studies. However, unfortunately, in a recent press release, the full data set is still pending. This Johnson & Johnson approach with the AD26 vector was not very successful, and the viral efficacy was 25%. However, the confidence intervals were high. And from their reports, the vaccine did not cause harm, unlike what we've seen with clade, with the AD5 vector. So the question that has come up is whether focusing on conserved regions can lead towards efficacy. And this is nice work done by Betty Korber summarizing the different vaccines that have gone into clinic. I've talked about the AD5 Merck vaccine constructs. More recently, Betty Korber, together with Tom Hankey, have been designing more conserved immunogens, some of them in the mosaic approach, and really trying to see if you can refocus the immune response from the highly variable regions that I mentioned natural infection tends to drive towards these more conserved regions that hopefully will not only lead to good T cell responses, but T cell responses in areas where it might be harder for the vaccine to mutate. And some of these constructs are moving into clinical trials. I'll describe these other approaches as well that have focused on really trying to identify highly immunogenic regions. So this is work done by a group in Spain where they have defined epitopes that have been associated with strong T cell responses, and then put those together in a beads on a string type of construct. And these are now in clinical trials with some early data presented at CROI earlier this year and ongoing studies. The other approach that I'll just briefly touch on is highly conserved regions. So this is work led by Jim Mullins at the University of Washington. And what they've done is really focus on gag, which, as I mentioned from the Merck trial, seems to be important in driving effective responses, and targeted some of the most highly conserved regions within HIV gag. And again, these vaccine constructs are moving into clinical trials. However, conservation alone may not be enough. So these are some early studies using the sequences from Tom Hankey and Betty Korber, and you do get some good breadth compared to the Merck vaccines, but again, the breadth may need to be improved. And here is data actually using the Janssen vaccine that I showed has just failed in a prevention setting. This was in a therapeutic setting. And again, unfortunately, even with a different viral vector, so here AD26 with an MVA boost, we still have as yet to achieve efficacy. So one thought is maybe the platform may be important. And this is nice work done by Hansen et al. From Oregon, the University of Oregon. And what they've done is put in viral sequences into a CMV vector. And CMV, as we know, is highly immunogenic and gives you very strong lifelong immunity. And in the rhesus CMV vectors, when they immunize monkeys with rhesus CMV expressing GAG, they see excellent breadth, but also notably, they see responses restricted to HLA-E. And HLA-E is a very interesting HLA because it doesn't have quite the same diversity as other HLA alleles. And in their studies, this is one study, but they've done multiple studies, essentially almost half of the animals vaccinated with these CMV vectors show early SIV control with long-term protection. So this is very exciting and has moved into a biotech company known as Vir, and early clinical studies have been initiated. Lastly, I will talk about immune modulation in the context of vaccines, and the various immune modulators that people are thinking about and using in vaccines: innate immune activists such as TLR7, TLR8, TLR9, checkpoint inhibitors, as well as cytokines. I'll touch on the TLRs, particularly TLR7. This is work done by Dan Baruch at Harvard in collaboration with Gilead Sciences. And in this therapeutic model, monkeys are infected with SIV, put on ART, and while ART suppressed, immunized with AD26 and MVA vectors expressing SIV antigens. And then a subgroup receiving both vaccine and TLR7, another group receiving TLR7 only. And the data showed that animals receiving placebo, TLR7, or vaccine only rebounded when ART was discontinued. In those receiving vaccine and TLR7, they did rebound, but a subset of them in this study, 3 out of 9, subsequently controlled to undetectable levels. And when you depleted their CD8 T cells, they rapidly rebound again, suggesting that CD8 T cells were playing an important role in controlling viremia. And so there's a lot of interest in doing these studies in humans, and several groups are moving forward with combinations of vaccines plus TLR7 in humans. In addition, in non-human primate studies, using checkpoint inhibitors such as CTLA4 and PD-1 has been associated with increasing the magnitude of the T cell response or increasing the durability of the response. The checkpoint inhibitors have been used in the context of HIV, and the safety profile needs to be really thought about and worked out. But this is interesting and encouraging in the context of thinking about immune modulation in combination with vaccines. Then lastly, I just wanted to touch on neutralizing antibodies, both because there's interesting preclinical as well as some early clinical data. So in this study, in collaboration between Dan Baruch at Harvard and Gilead Sciences, again, a therapeutic model, monkeys were infected, then ART suppressed, and while ART suppressed, received either TLR7 antibody or a combination of antibody and TLR7. And what was interesting is that all of the monkeys in the placebo group or the TLR7 only group or the PGT121, so the antibody group, all rebounded. However, almost half of the animals in the combination group did not rebound. And when they depleted the CD8 T cells in these animals, no virus rebounded, suggesting that this approach actually targeted the reservoir. And so in recent years, there's been a lot of interest in antibodies as HIV therapeutics, both in the context of therapy, but also in vaccination reservoir targeting, but more focused on passive administration at this point in time. And those antibodies can play multiple roles. They can work by direct opsonization, they can block viral entry, as well as driving cytolysis through effector cells such as NK cells and monocytes. And in recent years, due to good B-cell cloning techniques, there have been a number of antibodies that have been discovered that target various regions of the HIV protein. And this is a nice review done by Dennis Burton's group, looking at the various antibodies. And the key things to think about are the V2 antibodies tend to rarely achieve full breadth. The CD4 binding site antibodies are some of the best antibodies that we have, and you've probably heard of the VRC01 study that went into clinical trials for prevention. Unfortunately, no efficacy, but it was a single antibody study. N6 is another antibody in development. These take a longer time to develop in natural infection and tend to have very good breadth and potency. There's a V3 glycan antibodies as well, antibodies to the interface between GP120 and GP41, as well as membrane proximal antibodies that tend to have some concerns about autoreactivity, but some nice work has been done to try and minimize that. I just wanted to briefly also touch on some of our work where we've looked at kids who have long-term survivors of HIV infection. So these kids were infected at birth and presented to care in our clinical program in Zimbabwe at various ages, some of them well into adolescence. And many of these kids are perinatally infected. And this work was done before the immediate test and treat work. So we found that many of these kids were viremic, and their survival status was not so much based on T-cell responses, but interestingly, they made very good antibodies. And the older you were, the better the antibodies you developed. So similar to what I showed on the spectrum of antibodies that are available, it does take a lot of time to develop good neutralizing antibodies. So we identified in our cohort some strong neutralizers and would be very keen to move this into further study, whether it's in epitope mapping, and seeing if we can actually find broader neutralizing antibodies that are cross-clade and may fill the gaps of some of the currently available antibodies. So thank you for taking the time to listen. I've taken a little bit longer, but I've reviewed the data in the literature, shown a little bit of data that we have gathered in collaboration with various teams. Before I moved on to Charles River, I worked at Gilead Sciences and worked in the therapeutic vaccine group. So keen to acknowledge the team there who've been key thought partners as we've done this work. Thank you for your time.